Good morning, distinguished students, Chief Medical Director, sir, other members of the DIFF concept, on their open waves. You're all welcome to yet another class. It's already time, so we have to start 2 minutes after. And as usual, we'd like to take the second stanzas of our national anthem and the DIFF anthem, and then we see how it rolls from there. So please appeal to us to be on our feet as we take the second stanza of our national anthem, the DIFF anthem.
O God of creation, direct our noble cause, guide our leaders right, help our youth the truth to know, in love and honesty to grow and live in just and true. Great lofty heights attain to build our nation where peace and justice shall reign. Together bringing hope for the joy of mankind, committed to excellence, home and abroad, for the vain and beyond. Together we stand. God bless this legacy. God bless this legacy. Decentralized sectors, yet integrated, effective and harmonious workforce we are. Erase mortality, encourage research. God's grace is what we enjoy. More grace to this legacy. United, upholding the dream we all share. We pledge to arise to this clarion call. Our passion and service to God and mankind. God bless this legacy. God bless this legacy.
God bless this legacy. God bless Nigeria. We thank God for our country, the land of our birth. I don't know, there's Easter. The Easter period will be rounding up. The renting period is rounding up by this weekend. So we're in the Passion Week or Passover Week. The Muslim friends also are also be rounding up the Ramadan period in about 2 weeks or so. Nigeria has come to stay. That's why God made it in this challenging period. We're having Lent and the Ramadan period about the same time. We'll continue to pray. Nigeria has come to stay and Nigeria will stay together. Before we introduce our guest lecturer, I'd like to welcome each and every one of us again, and we hope that others will join us as soon as possible. Maybe they are celebrating Easter. I know 1 or 2 people travel because of Easter, but I believe that our lecture must continue. We must continue to empower you. Please invite Ebony Waves to give us a song by one of our own in Nigeria of repute. For us in old school, we know her very well. Obaro by A.V. Edna. Let's put our hands together for the Ebony Waves as they come forward.
Mami gbogbo si dabe, o ma sobe ube, ahiwo gbogbo reno orise, wa shamanyaro, efe kubu so harera o wa somai, chakorete mo pro, wa shamanyanya obaro, nya obaro, wa shamanyanya obaro. Wajomanya obaro, wajomanya obaro. Ogaro gane ogaro bo marinya nebedete bede maeja oho omore de budenye ibakote maha ogane melo wero nana roko mai mayo yogo wajomanya nya obaro wajomanya nya obaro wajomanya nya obaro, wajomanya obaro. Wajomanya nya obaro, wajomanya nya obaro, wajomanya nya obaro, Wazomanya nya obaro. Nya obaro. Wazomanya nya obaro. Nya obaro. Wazomanya nya obaro. Wazomanya obaro. Wazomanya nya obaro. Nya obaro.
Thank you, Ebony Waves. Thank you, thank you. You see these rare steps I gave. In those days, we'd have dump and jump and all those things. That time, we're younger and stronger. But now we're wiser, so we take it easy. It's forward ever and backward never. These songs I know. But there are certain songs they sing that we don't know them. But you know, we have youth here. We have so many of you young here. I have several teenagers that are getting pregnant these days that we're registering them. Within the last 3 to 4 weeks, I've registered about 5 or 6 teenagers that are getting pregnant. And, well, let me not go into all the details. A few days ago, Americans sent some astronauts. As early as 1968 or so, I think one of the people that went outside the space, his name is Yuri, I can remember that name. But a few days ago, 4 astronauts were sent to the moon again. One of the people is a black man. They say this is the first time a black man is among the team of 4 people that will be going to the moon. And a female is also among those people. And I was very happy that there's nothing wrong with the man of color, but we Nigerians, there's something wrong with us. We need to change. If we go outside, we are performing well. I'll come back to that again when I introduce our speaker. Yesterday, the world celebrated 75-year World Health Organization, WHO, 75. Tremendous progress has been made in our health care delivery system across the globe. Where are we? About 40 years ago, Nigeria, Indonesia, Brazil, Malaysia, Singapore were almost at par, socioeconomically, health indices and everything. We are far, far backward. Brazil has gone ahead. Singapore has gone. Malaysia has gone. Coming nearer to us here, Saudi Arabia and Egypt, they are far behind us. We are importing and sending doctors to go and help them. We are sending drugs to Saudi Arabia. The Nigerians started running to, they are going there now. They are jabbering to Saudi Arabia. Why? What is the challenge? What is wrong with Nigeria? I think it's leadership. But I believe that God will give us the right leadership at the right time. I'm happy that we're making progress. When your child is in the womb, as early as 18 weeks of the pregnancy, your child will begin to hear sound. They can hear sound. And between 27 and 30 weeks, the child knows the voice of the mother. He's beginning to distinguish. And by the time the child is delivered, the child will be able to hear just like me and you are hearing. But we will not know whether that child is hearing. Technology has advanced to the level now that we will know whether your child at birth can hear or not. And thank God for the progress. When I mentioned about a woman being among the team going to the moon, I mentioned women. We've had distinguished female here, very erudite scholars that have been giving us lecture. Dr. Alima, Dr. Uche. Today we have a privilege to have another woman to talk to us, a lady to talk to us, and a woman that has passion for her job. She's an ENT surgeon. They have modified the name these days that I don't want to break my job. Maybe she should call what otolaryngoscopy or laryngology is. She'll be talking to us today about newborn hearing screening. She's a distinguished fellow of the West African College of Surgeons. She's a wife to one man. I heard in East Africa, a woman can marry 2 men and all that. You know, this daughter of Eve is married to only one man, and she's blessed with 2 boys and 1 girl. Am I correct? Oh, it's 2 girls and 1 boy. Okay, 2 girls and 1 boy. She has passion for publications. She has written a lot of papers, both locally and internationally. And she's somebody that I call a team player, somebody that has a very good human relation. Of course, to see her, to consult her. My wife have seen her, my daughter have seen her. Several of us have had reason to see her. She'll be talking to us today. Can your child hear? What can we do to know whether your child that was born is hearing? And it's my honor and privilege to invite to the podium our own Dr. Yemisi Oyedepo, sorry.
Good morning, everybody. I want to appreciate the medical director, the CMAC, for having so much confidence in me and for this opportunity to present at this antenatal class. I want to welcome everybody here, fellow consultants, other doctors, and the special guests here, that's the antenatal patients. You're welcome. This morning I'll be talking about newborn hearing screening. That's screening done to detect hearing in newborn babies. We're all pregnant now, and I know that by God's grace we'll deliver safely and there will be no problem by God's grace. Now, it is not just to have your baby and then, oh, my baby is out, no jaundice, no fever, the baby is sucking, I'm going home. No, that is the normal practice, but things are beginning to change now. Screening, what is screening? Screening is a public health service in which members of a defined population who do not necessarily perceive that they are at risk or they are affected by a disease or its complication. People who don't even think they have any problem, they think everything is normal, they don't have any symptom of any disease. But you now call such people and start to ask them questions, or you do some tests for them because you want to detect, something that if you detect early can prevent a lot of havoc. Of course, most people will see no reason why they should undergo the test. I don't have a fever. Why do you want to do malaria test for me? But there are some conditions where, fine, in medicine, there are some clinical conditions where you wait for symptoms to manifest before you run tests. But there are some, and most of these are non-communicable diseases, where you don't wait for symptoms. In fact, by the time you start to have symptoms, it is too late. And this is one of the things that we're trying to bring our attention to. And this is a program that we're starting from here, but we believe that very soon it will become a national program by God's grace. These tests that are done during screening does not harm the patient. It usually helps them to detect early this disease you are looking for, and then to reduce the risk of the disease or its complication if they are found to have it. Now, newborn hearing screening is actually a cost-effective method of delivering early identification of congenital permanent hearing impairment. A lot of children are born deaf, but we do not know. Unfortunately, deafness is an invisible disability. You don't see it. You can't tell that someone is deaf by looking at the person. You can even hazard a guess for blindness. You can for other deformities, but not for deafness. And then the screening probably comes with a cost, but it's cost effective because you want to identify early congenital hearing impairment. That means the child is born with an hearing impairment. And usually when they are born with hearing impairment, it is permanent. It's a permanent disability that doesn't reverse. What is the aim of this newborn screening? It is to identify early and to intervene, and then to follow up infants and young children who are deaf or hard of hearing, children who are born deaf. You want to identify that this child is not hearing at birth. And then when you detect that, you want to start your intervention immediately so that the child can grow up like every normal child, hear and speak like every normal child. In many countries now, like in the US, in the UK, Australia, New Zealand, many countries in the European Union, it is routinely done for every child that is delivered. In fact, if you don't agree to do it, you are going to be made to sign a lot of forms to show that you are liable if this child grows up deaf. You are the one who refused to screen your child, you know. So you indemnify the government of any guilt or any fault if you refuse to screen your child. This is not like a routine. Once your child is born, you must do it before you're discharged from the hospital. Unfortunately, Nigeria is still way behind, and that is part of what Dr. Husman was trying to say. Way behind because the equipment are not even available. I don't know of any government hospital that even has the equipment in Nigeria as we speak, not even in Abuja. The only place that had the equipment had old one that had collapsed for like 3-4 years now. So it's not available. So how do you offer something you don't have? And then manpower, you know, is not, then so the information is not even available for people, to people. So it's not, we're still way behind talking about newborn hearing screening, but we are not going to lag behind with other people here. Now, hearing loss is the most common congenital birth defect and is a sensory disorder. Sensory disorders are disorders that have to do with senses. You know, we have 5 senses: sight, hearing, taste, perception, and feeling, and proprioception. So hearing is one of them, and it is actually the most common congenital birth defect, but we do not know. It has been found out that 1 to 2 out of every 1,000 babies are born with permanent hearing loss, either in one ear or both ears. 1 or 2 out of 1,000. And then this incidence increases up to 1 in every 100 babies for babies who have spent more than 48 hours in intensive care. A lot of babies are born and they have to be referred to the intensive care for one reason or the other. Once the baby spends up to 48 hours there, they actually have like 10 times more chance of having this permanent hearing loss. Most of these babies don't have a family history of hearing loss. There's nobody in their family who was ever deaf. Their father wasn't deaf, their mother, nobody in the father or mother or the maternal family that had deafness. So you don't even have any reason to suspect that this child might not hear. Now, infants that have not been identified before they clock 6 months of age, they usually have delays in speech and language development forever. Before it used to be, oh, maybe 2 years, the age of hearing is 2 years, the age of speaking is 2 years, and then if you catch them before they are 2 years, you can still rehabilitate, but it has changed. It has been found out that if you have not identified this child before 6 months, chances are the child is not going to be at par with his contemporaries when it comes to speech and language formation. It's not going to happen. Even if you detect at 7 months, it's not going to be. 7 months, the child might eventually get to speak, you know, but it will never be like a normal, you know, the hearing and the speech will not be the same. So that is why early identification is very important. And then when you identify such a child very early and then you intervene, it can prevent a lot of severe psychosocial, educational, and linguistic repercussions. What am I talking about? A child who cannot hear has a lot of psychosocial issues. And they have temper tantrums because they are frustrated. They can't talk, they can't express themselves, they can't hear what everybody is saying. Even when the child grows up, it's still the same thing. They feel you're talking about them, you know, everybody's making fun of them. The child cannot blend with other people. It causes a lot of psychosocial issues for the child forever. The child lags back in education, especially in a country like Nigeria where we don't even have special schools everywhere. So that kind of child will just be sent to a regular school and be coming last in the class and repeating the class. Sometimes it gets to the point where it's like the child has repeated the class twice before the parents start to think, is it that this child is not hearing? And then linguistic repercussions mean that the child cannot even talk. So all of this can be prevented by detecting whether the child can hear as early as possible. When you intervene before 6 months, the child will develop normal speech and language like any other child. In fact, nobody will ever know that the child was born deaf. the child will develop early, very well, like any other child, will hear well, will talk well, will be a parrot, like any other child. Now, what are the misconceptions? The things we think that are actually wrong. I want to clarify some of them. So one of the misconceptions is that some people think that, oh, parents will definitely know if their child has a hearing loss by the time their child is 2 to 3 months of age. Okay, by the time it's 2 to 3 months, you will know. You know, when you talk, you will notice the child will answer you. The child will turn towards you. When you call the child's name, the child will turn the head, then you will know. No, that's not correct. Before this universal hearing screening started, that is being practiced in the rest of the world, the average age at which parents found that their children or suspected that children had hearing loss was 2 to 3 years. The child will be like 2 to 3 years. At the time when they go to church, they go to social gatherings, they see the other children are talking and chatting, and their own child is not talking. Initially, they feel, oh, children are different. This one is just, a slow talker. He's not going to speak early like any other child. Even my grandmother told me that when I was also a child, I didn't talk until I was 4 years old, and all these things that people say. So normally it's about 2 to 3 years that people will naturally discover without hearing screening. And then children that have mild to severe to moderate hearing loss. If a child has very severe hearing loss, very bad, can't hear anything, that one is even the one you detect around 2 to 3 years. But children that can hear loud shouts, they have mild hearing loss or moderate hearing loss. They can hear, but they can't hear well. Those ones are even more difficult to detect. And those are the kind of children you will beat and beat and beat. Say, this child is very stubborn. I've told this child, stop. But the child is not hearing you only when you shout. That's when the child hears. So I had one case this morning, and we'll come back to that later, because I was almost crying before I came here when the mother was telling me how the father was belting the child yesterday, beat the child until the child was red. She was telling me in tears that I should please, and the father refused to follow them for the test, that I should please, she wants me to talk with the father. When she gets home, can she place me on call with the father and talk to the father, So you think the child is just stubborn. No, the child is not stubborn. The child can't hear you, and the child is very frustrated. Now, parents can identify. Another misconception is that parents can identify a hearing loss by clapping their hands behind the child's head. They'll tell you that, just clap. When you clap, the child will turn. Then that child hears. No. Children that have hearing loss, they compensate with other organs. If they can't hear, their vision is very sharp. Their proprioception is very sharp. Their feelings are very sharp. Compensate. So that's your hand movement you are using to clap. The child can see the shadow of your hand and is turning to look at the shadow. The child can feel the breeze of your hand over his head and is turning to look at your hand, and you think the child is hearing. So there's really no crude way that you can use to confirm that the child hears. Another misconception is that the high-risk register is all that is needed to identify children with hearing loss. I'll still talk about the high-risk register in the next few slides. High-risk register is simply a register of conditions that predispose children to hearing loss. Children that have asphyxia at birth, the mother had infections like cytomegalovirus, all this Touchy syndrome, all this, meconium aspiration, things that places a child at high risk to develop hearing loss. So people feel that it's only those kind of children that should be screened. Other children don't need to be screened. There is no risk. Why? That they don't have a family history. Why should you screen them? But that is wrong, because about 50% of children that are born with hearing loss, they don't even have anything to do with the high-risk register. They don't have any risk factors at all. So that's, if you use that high-risk register to determine those who you are going to screen, you are going to be missing about 50% of children that have hearing loss. So that is why every child must be screened. Another misconception is that hearing loss does not occur often enough to justify the use of universal screening programs. But that is wrong. If it affects approximately 2 to 4 out of 1,000 live births, then it is actually one of the most common congenital anomalies. All this phenylketonuria, sickle cell disease, and all of that. Worldwide, the incidence is not up to this. So it is frequent. It is that 1 or 2 or 4 children that will have it among 1,000. They have 100% morbidity. So it is significant enough. Because of the sake of those 4 children out of 1,000, it is significant enough to screen every child. Another misconception is that tests are not reliable and that they cause too many infants to be referred to specialists. Okay, you do a test, okay, then I have to refer this child to a specialist. They spend money, they go up and down. These tests are not reliable. No, that's not true. With universal hearing screening or newborn hearing screening, the referral rates are just as low as 5 to 7% from statistics and from data. So it doesn't cause over referral or wrong referrals. No. Referral rates of 5 to 7% is acceptable. And a lot of the tests are reliable, very reliable. There are levels of testing until we get to the diagnostic testing. So this is just screening. The screening will isolate a child, and then you can find, there are ways of confirming before you can make a referral. Another misconception is that there is no rush to identify a hearing loss. The loss does not need to be identified until the child is aged 2 to 3 years. That is fallacy. By the time the child is aged 2 to 3 years, it's almost too late to correct that hearing. It's almost too late because at that time, once they are more than 6 months, like I said earlier, they develop normal speech and language like their peers, but after 6 months. But by the time the child is 2 to 3 years, it's late because there's something we call neural plasticity, and it has begun to set in. That's part of the brain that God has made for the child to hear. It begins to get reassigned to other functions. Oh yeah, you go and help with sight, go and help with feeling. So at that time you want to rehabilitate the child, but the portion of the brain to process the speech or the language or the voice is not there again. Then the last misconception I want to talk about is that children that are younger than 12 months cannot be fitted with hearing aids. Okay, even if you discover that my child cannot hear well, will you now give hearing aids to a baby? Yes. We give hearing aids to baby of 1 month old. Even babies of 1 month old can have cochlear implantation. So intervention can be done as early as possible. The prevalence of hearing loss, like I said earlier on, is greater than most other diseases and syndromes that are screened at birth. All these other syndromes that are screened at birth, more globally, hearing loss is actually more common than them. And it is estimated to be more than twice that of other screenable newborn disorders combined. All the other screenable newborn disorders, combine them together, hearing loss, the incidence is twice. So now, neonates that spend their time in NICU, they have a higher occurrence, like I said earlier on. And then children that are born extremely low birth weight children, you talk about grams or 1.5 kg, those kind of babies, they actually, and they have to be in NICU. They have to be in NICU to survive. It's not that NICU is a bad place, but they've been found to be predisposed to hearing loss, and we'll still talk about that later as the presentation goes on. So these children too should be helped. That they went to NICU does not mean they should lose their hearing. Even if they developed hearing loss from that, intervention can still be done at that age. And then 1 in every 811 infants that does not have risk factors for hearing loss, and then 1 in every 75 infants that has risk factors for hearing loss develop hearing loss. So if you have 811 children that they don't have any of the risk factors for hearing loss, 1 will have hearing loss. And if you have 75 infants with risk factors, 1 is likely to have hearing loss. What are the risk factors? I talked about NICU admission. The things that predispose to hearing loss in NICU admission is just the high frequency ventilation, the ventilators. Then they are likely to develop jaundice, what we call hyperbilirubinemia. Jaundice is another thing that can cause hearing loss in children. Low birth weight, because they have low birth weight, they are actually prone to develop. That's low birth weight, or even when they are premature, predisposes them to hearing loss. And then when they are on admission in the NICU, a lot of times they are on antibiotics, they have sepsis, and so some of these antibiotics that might even be the only thing that the sepsis is sensitive to predispose the children to hearing loss. So even the ones that did not have, they were not born with it, but the treatment the child had at NICU can also predispose the children to hearing loss. That doesn't mean that NICU is a bad place. NICU is necessary for that child to survive, like I said earlier on. But we can still intervene and still prevent the child from developing hearing loss. And all of this puts them at risk for progressive and late onset hearing loss. Now, what am I trying to say? It doesn't mean that the day as the child is in NICU now, the child develops the hearing loss. No, sometimes it's after when they're out of NICU. Progressive hearing loss, it develops over time. Yes, it doesn't have to be immediate while they're in NICU. It might be months after, but that is a risk factor. And that is why those kind of children must be routinely screened to monitor them until they are 3 years, and then you're sure they are fine. Now, what is this high risk register I was talking about? These are the people in this register. People that have a family history of permanent childhood sensorineural hearing loss. People that have a family history of deafness. Don't mind the grammar. People that maybe somebody in the family was deaf, you know, father's family, mother's family, grandfather, grandmother that was born deaf or that developed deafness along the line. You know, those people are at high risk of having children that will be deaf. And people that have mothers that have infections like cytomegalovirus infection, rubella, toxoplasmosis, herpes, even malaria. Then children that are born with craniofacial abnormalities like Apert syndrome, Crouzon's, Trichacoli, these children that have abnormal bony formation of the face. Maybe some of them, like in Apert now, the skull fuses very early. All the bones in the body, they fuse very early. Normally, as a child is born, there's what we call anterior fontanelle and posterior fontanelle. They are meant to like be open. That one you feel every day and put oil on it. It's meant to still be open until a particular age. The one at the back closes at 6 months, and the one in front by 18 months it should close completely. This gives allowance for the skull to expand as the brain is growing big. But in some children, by the time they are 1 month old, all those fissures, fontanelles, they have fused. So it causes the head becomes so small, and then as the other structures are developing, there's so much pressure everywhere. It can also cause hearing loss because it also affects every bone in the body, in the ear, and every part of the body. Trichacoli too is like that. That one too has like hypoplasia of the mandible and zygoma, you know, or even the orbital rims. They just have funny face, like the face is sunken inside. Any of these craniofacial abnormalities can actually predispose a child to hearing loss. People that have jaundice at birth, especially the kind of jaundice that requires the child to have extreme blood transfusion. Children with persistent pulmonary hypertension, and then that have to be that is associated with mechanical ventilation. Well, still talking about ventilator. And then we have postnatal infections like meningitis. Children can develop meningitis after birth. Even a child that was born hearing can develop meningitis after birth, can develop a viral encephalitis, and this can totally wipe off the hearing. I still remember vividly a child of 9 years that was ill, had a very high fever, and was taken to the hospital, was on admission, and they were giving antibiotics, IV, and then suddenly one morning the child woke up and said, "Mommy, I can't hear anything." Everything just went deaf. And the child developed profound sensorineural hearing loss. And what we couldn't determine was whether the hearing loss was due to because the child was being treated for meningitis, but we believe the child had encephalitis, which is actually worse and more likely to cause hearing loss. So whether it was the encephalitis that caused the hearing loss, or whether it was the drugs like gentamicin and chloramphenicol that were given to the child, either of them. But these kind of infections are bad, and they can actually wipe off a child's hearing. There are other syndromes that are associated with progressive hearing loss, like as the child grows, the hearing loss develops and worsens, like neurofibromatosis and the Usher syndrome. There are other neurodegenerative disorders that affect the neural development, and then these are Charcot-Marie-Tooth syndrome. I don't want to bother us with all these names. And then people that are also at high risk, included in the high risk register, include parents or caregivers that have concern regarding the hearing, speech, language, or developmental delay. They've noticed that this child It's like this child is not when I bang the door of the house. This is coming very low down in the ladder anyway. You know, when I bang the door of the room, this child does not even startle at all. Doesn't even wake up. Even if you are playing music and the child will just continue sleeping. Is this child hearing? These are children that are also included in the high risk register. And then children that have recurrent or persistent otitis media with effusion that lasts more than 3 months can also are at risk of hearing loss. Why screen every newborn? We have to screen every newborn because a high risk register as an indicator for screening is not adequate. It misses a lot of children, so every child should be screened. We found that 50% of all the newborns that had hearing loss, they were discharged from the well baby nursery. There's something they call well baby nursery abroad. Just like you have your baby is with you. You didn't have to go to NICU or SCBU. So most of them, 50% of children that developed hearing, that were found to have hearing loss, they were born normally and they didn't go to NICU or anything. And they had no risk factors for hearing loss. So every child must be screened. Every child must be screened regardless of the risk. Now, children who are at risk, I've mentioned the people in the high risk register, people that are at risk of developing hearing loss. They should actually, and if those kind of children, when they are born and they have the first screening, if they pass, they should actually be evaluated every 6 months for the first 3 years of life until they are 3, and you have seen that hearing and speech has been well formed and developed. You continue to evaluate them every 6 months because some of these congenital issues may not manifest fully at birth. Some of them are progressive, like I explained. So some of them, and even some of these causes are acquired, not necessarily congenital. Like the other things that happen after the child was born, like being taken to NICU, giving some drugs and things like that. So any child that is at risk must be screened every 6 months for the first 3 years of life. And all of this is just aimed at identifying the hearing status changes early. Any hearing status change you see, you want to identify it early so that intervention can be done early. Please, I want us to remember that intervention for hearing loss in children is 6 months. It is not 1 year, it is not 2 years. Now, how efficient is this early identification and intervention? By 1998, in the United States, before they started this universal hearing screening in the United States, averagely hearing loss in children, they were picking the hearing loss, children that had hearing loss at the age of 2.5 years. The child will be 2.5 years before they pick that this child has hearing loss. And then when they now started this universal hearing screening program, do you know that the age of diagnosis of children with hearing loss reduced to 3.9 months? Average age of diagnosis of children that had hearing loss. From 2.5 years, when it's too late to intervene, kind of too late to intervene, reduced to 3.9 months of life. And then, mean age of intervention, when you diagnose by 3.9 months, by the time the child is 6 months old, they had already intervened, and this really, really has improved the quality of lives of these children. So now, early identification is now defined as diagnosing the child as early as 3 months. The child must be diagnosed by 3 months. It is intervention that is 6 months. So, children with hearing loss, like I said earlier on, they always experience significant delays in language and speech and then academic achievements. So we also found out that children that were born with hearing loss that were identified by 6 months, they had significantly higher receptive, expressive, and total language quotients than those that were identified at 7 months and above. You might wonder what's the difference between 6 and 7 months. There is. Intervention before 6 months made a lot of difference to how the child's hearing, the child's speaking, and the total intelligence of the child that was developed, that was discovered, that had intervention at 7 months to 12 months, or 12 months to 18 months. In fact, this study actually stopped at 35 months. They didn't even bother talking about children beyond 35 months because for them it was just too late. So the difference is really clear. And that's If you intervene in a child that has hearing loss at the age of 7 months, or you intervene at the age of 12 months, or you intervene at the age of 18 months, once it's beyond 6 months, all of them, the prognosis is the same thing for all of them. The same thing. Whether you once it's more than 6, whether you intervene at 6 months or 9 months or 12 months or 18 months, it's just as good as intervening at 18 months, even if you intervene at 7 months. So the main goal of early identification is to improve the speech and language development of children who are deaf. Now, legislation is needed to implement this program on a national level, like it's done in many states in the US. It is actually part of the legislation in the US. It is a law. You know, you have to screen your child. And I believe that we'll get there in Nigeria. Even though there are still some states in the US that have not passed that legislation, but most of the states have already passed it. Now, what are the methods of screening that are available? Most of the universal hearing screening programs, they use what we call automated OAEs, auto-acoustic emissions, and then automated auditory brainstem response. What are auto-acoustic emissions? You just place a microphone in the child's ear, and then it detects some sounds. Cochlear microphonics, we call it cochlear microphonics, that is produced from the cochlea. Let me just let us know that how do you hear? Sound enters your ear from this outer ear, goes to the middle ear, from the middle ear goes to the cochlea. I'm sure we all remember cochlea in biology. That is where the center of hearing is. Then, but from the cochlea, it also goes through nerves to the brain. So now, this OAE, what it basically does is to detect the functionality of the cochlea. There are some sounds that are generated by the cochlea on there. When you put a microphone there, cochlear microphone, you pick those sounds. Those ones are called spontaneous OAEs, but nobody does that for screening. What we do is what we call distorted product OAE or transient evoke. That means you put a probe in the child's ear and you give some stimulus, some clicks that is supposed to elicit some responses that your microphone will pick up. When you do that, you get the right response. The machine tells you this child has passed. The cochlea is functioning well. So that is what we call OAEs. It's a very short procedure, it doesn't take time, and it's usually done in babies. You don't even need to sedate them because most of you just go when they are sleeping. It's not painful, and then this is a very easy way to. Once the child has passed that screening, you can say that this child hears well. Any child that fails the OAE, you will have to do what we call the AABR, Automated Auditory Brainstem Response, because you want to be sure. That's another screening test. That's the next screening test. But a child that passes does not need to do an AABR. But if you fail, you go on to do an AABR. But before you do an AABR, of course, you want to repeat the OAE a second time. You do the first time, the child fails. Sometimes movement or noise, because OAEs require a very quiet environment to do. Noise can interfere, the baby's movement can interfere. You don't want to do it when the child is sucking, because even the sucking movements can interfere. And then sounds of the incubator, the ventilators in the NICU or incubator, all these sounds that are the staff that are there, all those background noise can actually interfere with the test. So you want to repeat it again in a very quiet place, and then you also want to make sure that the ear is clear, there's nothing in the canal that can give a false result. So when you repeat the OAE and then it fails, then the child goes on to do an AABR. Now, any child or infant that has been on admission in the NICU for more than 5 days must have an AABR. It's not an OAE alone for this kind of child. Now, I'm going to say why this is possible, why this is necessary. I told us earlier on that the OAE, it tests the integrity of the cochlea. The AABR tests the integrity of the pathway from the cochlea to the brain. It tests the neural pathway, because sometimes the cochlea is even fine, but from the cochlea to the brain, the nerves, and that is where all this NICU stuff comes to cause damage. That is where all this exposure they get in NICU really causes damage. The neural pathway. That is from the cochlea to the brain. So you have to do an AABR so that you can test that part that transmits sounds from the cochlea to the brain. Now, that AABR2 is also a simple test to do. That does not even require a very quiet environment. And that one will also tell you whether the child has passed or failed. A child that has a normal cochlea but has an abnormal pathway from the cochlea to the brain, we call it, this child, we call them children that have auditory neuropathy. They still don't hear well. The child can actually hear sounds because the cochlea is fine. The child will hear sound but cannot understand speech. That's the difference. The child will hear sounds but cannot, the sound he's hearing will not make any sense to the child. You are talking, the child knows people are talking, but does not understand, can never understand speech because the neural pathway that is responsible for hearing, for that process is actually has been affected. This is a picture of a baby that is having an OAE done. You just place a probe in the ear. You measure first ear, second ear. It's a simple procedure. Now, I already talked about the AABR, what it does from the cochlea to the eighth nerve. And it is actually found to be more reliable. The results for AABR is more reliable after 48 hours of life. Most of the children that have been tested with AABR within the first 48 hours of life have a false negative. So the reliability increases when the child is 2 days and above. So that is when we recommend an AABR be done. So it's usually, like I said earlier on, a screening test for those who require follow-up testing or who failed OAE. And then it's recommended in the NICU setting with at-risk infants. It gives a pass or fail result. This is an AABR being done. In this one, you place electrodes over the forehead, the mastoids, and then you also place a microphone, a earpiece. Sometimes you can use an earpiece, and then sometimes you can use a headphone over the ears to deliver the sound, and then it traces the pathway. Most of the time, we actually use a probe. You can see a probe is being used in this instance. Now, when a child feels both of these, feels the OAE and feels the ABR, that's when we now talk about the diagnostic ABR, auditory brainstem response. When the child has failed, but this is not a screening test, this is a diagnostic test. So this one measures decibel by decibel. You can start from 20 decibel, 40 decibel, increase the sound until it's very loud, 80 decibel. It will measure, there are some waves that are meant to be generated and picked at particular intervals. That is what we look out for. That would actually confirm to you if this child hears or not. So if the child does not hear, you can pick it with a diagnostic ABR. And that is the confirmation. But of course, for the newborn hearing screening program, you don't have to do a diagnostic ABR. Once the child has passed, that's fine. The diagnostic ABR is reserved for children that have failed, because this ABR will tell us the severity of the hearing loss. It will tell us where the wave started to get generated, whether it was at 40 decibel, whether it was at 60 decibel, whether it was not even generated even at 80 decibel. And that determines your intervention. If from the ABR you discover that this child hears at 40 decibel, 50 or 60, that's still a candidate for hearing aid. Let's use hearing aid, let's augment the hearing, and then the child can hear. But if you have a profound hearing loss, a child that does not hear at 80 decibel, that is cochlear implant straight away. That's the only thing that can help the child to hear. And I can tell you that children are implanted as early as 2 weeks, 4 weeks, 6 weeks in developed countries. And the moment they are implanted, the child lives a hearing, the child actually lives a normal life, develops normal speech, normal hearing, normal intelligence. Now, follow-up testing. When is follow-up testing done? It is usually done for infants that failed the initial hearing screening at birth. They should return for follow-up testing within a month. If you've done testing for the child at birth, failed the first one, failed the second one, the child should come back in a month's time. Now, and this follow-up testing just allows for multiple test sessions. Before you label that this child is deaf, let's do this, you just want to be very sure. It allows for multiple test sessions and medical interventions in case there's there's some instances where you can actually do some medical interventions, like in children that have this recurrent otitis media with effusion, that can still have some drug intervention, and then you still keep on checking and be sure that the child is now hearing. It also allows for parents counseling and appropriate amplification before the child is 6 months old. So in children that have failed all of this, then we do a comprehensive audiology test battery. This is what I talked about. You do that. At that point, you do it in panometry. You do an ABR, OAE, acoustic, everything. You do the whole. You trace the hearing from the canal to the brain. Now, when the child is more than 6 months of age, the children must be sedated because they won't really have that kind of deep sleep. You want to put a probe in their ear, they wake up, or they turn, they are moving. And the moment you are doing this test and the child is moving, or the child is not still, you get a false result. So because you don't want a child, you don't want to label a child that is not deaf, you must sedate the child. The child will sleep, and then you can do your test and be sure the result is reliable. And this, of course, the information you get helps to determine the kind of amplification you offer. I want to tell you, the good news is that all of this is available here at DIFF Medical Center. About 38% of infants are born in countries where newborn and infant screening is minimal or absent. Like Nigeria, it's practically absent or very minimal, just in a few places, you know. So about 38% of infants all over the world are born in settings like this that don't have the facilities. And we want to encourage all mothers to screen their children for hearing loss at birth. You have your baby, let's screen your baby, you get a pass, you're happy, you go. You don't lose anything. If your baby is screened and you are told that your child passed, you don't lose anything. All children that are admitted in NICU should be screened with AABR at discharge or before discharge, or at worst in the clinic, can be given a clinic appointment shortly after discharge. And all the children that are at risk should have follow-up visits. Interventions, we can have hearing aids in them. There are different kinds of hearing aids. This is a behind the ear hearing aid. You see how it fits perfectly with the child. And the earlier the child starts to wear the hearing aids, the earlier he gets used to it as part of his body. So you won't be removing it. But when you start putting hearing aid for a child that's already 1 year old, that already knows what is supposed to be on his body or not, he will keep on pulling it off. But once you start putting it as early, the children even themselves know, once you put the hearing aid, they know that they can perceive sound. There are a lot of videos online where you see children were fitted with hearing, babies were fitted with hearing aids, and they started smiling and laughing immediately because they could hear. But you remove it, they change their face because they know what's happening, I can't hear again. So you can even see the reaction on the child, that the child is hearing. And so the child does not want to remove the hearing aid himself because he knows that when he removes it, he can't hear. And that is why early intervention is actually very important. This is cochlear implant. This one is surgical implant that is put in the cochlea, more like to replace the cochlea that is not functioning. Even in cases before, the teaching used to be that when you have cochlear damage from meningitis, the child cannot benefit from cochlear implants, or when you have incomplete tones of the cochlea. But now a lot of things have changed. There's what we call extended electrodes that you can even use in children. In babies that have meningitis, what does it do to the cochlea? It makes the lumen totally blocked, so you don't even have a place to put the electrode. But now we have advancements that can even overcome that. And this is the children hear well. This is how the cochlear implant looks like. So, in conclusion, I want us to remember that identification of all newborns with hearing loss before 6 months is attainable and realistic. By the age of 2 years, the hearing impaired child has already experienced irreversible delays in speech and language development. And by this age, neuroplasticity sets in, and in the hearing center, and the brain gets rewired and reassigned to other function. This morning, with the permission of the mother, she said she wanted the child to be used to teach. We had one. Unfortunately, this child is going to be 4 years next month. And the child has been noticed not to hear well and things like that, but different people telling them, no, This child is just different, you know. And at some point, the mother actually took the child to a teaching hospital where they were. And I don't know what they did, but apparently they didn't have the right equipment. They just did some behavioral test for the child and said the child could hear. The child should go for speech therapy. And she's been doing speech therapy till the child is almost 4. The child can't hear anything. So she's just coming now, and we're diagnosing that the child has, you know, quite profound hearing loss. And it's like, where do I go from here? You know, she's pregnant now. She already asked at the front desk, how do I register here? Because she wants to have a baby in the right place. She was crying, she was just like, you know, lamenting about so many issues that the child has, and how the father will get angry, flog the child, you know, and so many things, and how when the child came this morning, was crying and scattering the whole hospital and everything, you know, because they have a lot of issues themselves. They are usually in bad moods at times, and that's why sometimes they are mistaken with autistic children. But when you do this test, you know, it clarifies what exactly the child has. So early diagnosis is very, very vital. We pray we still find a way to get around this, but these children at this age are not likely to develop normal speech. At worst, you can help them hear sounds, or at best, you can help them hear sounds that will protect them, like they are crossing the road, they can hear the horn of a car. The car is coming, you know, they can just move away. But for that kind of child to hear well, engage you in conversation, and talk like normal children is almost not possible, except by the divine intervention of God. Thank you very much.
Thank you very much, Dr. ABC. This is loaded. Please take your seat. I did an ENT posting as a medical student in 1988. I was just trying to calculate how many years ago now. This is loaded. So the things you taught us today, I've never had them. So they are she's really loaded. And last month, on the 3rd of March, the world did World Hearing Day. And today we are trying to let you know that hearing is becoming a problem now. And like we have heard from the statistics that she has given us, it's the commonest among all the sensory losses that people can have. And so we know that this is a big issue. I want to, once more, let's put our hands together for this. Some of you may not understand. Even me, some of the things that she taught, I don't understand them. But the major thing is early identification and intervention. And before the age of 6 months. If there's nothing we did not take home today, is this. It's very shocking, alarming, that the whole country like Nigeria, no government hospital can do this test. No government hospital. It's very, very alarming. Thank God that she said we can do it here. The only thing that will prevent you people from wanting to test, we were all born like that, just thrown into the society and all that thing. Nobody even scared us, so nobody even knew whether we were boys or girls now. But technology is improving every day. And we thank God we have sharp brains like this. Last 2 weeks, we talked about jaundice in pregnancy and in neonates. And now we know the effect of one of the effects of jaundice is what you have just taught us today. That even jaundice can cause. Drugs that mothers take during pregnancy can go to the babies and can affect their babies. We have very senior people here, doctors, led by Dr. Dawsa, our Chief Medical Director, Dr. Alima is here, Dr. Konkwe is here, Dr. Barao is here, our Chief Resident, our head nurse are here. There will be a lot of questions and answers. But we need to celebrate this, our mothers. I invite members of Ebony Waves, let them come. Start coming to give us something about Sweet Mother today while we are celebrating our mothers. Your babies will be safe if they are going to be delivered. It's just the cost of doing this test. And normally when you deliver vaginally, two weeks, if you deliver, 2 days, if you deliver by cesarean section, baby is fine, no challenge, maximum 5 days you go, except your baby has to go and stay in NICU. So Dr. Lima can arrange and do, Dr. Yemisi can arrange and do this test for you before you leave this hospital. She will come back here. As she's answering questions, she will tell us how much does it cost to do this test. Me, I'm hearing of AOB, AABR. I don't understand this thing. She'll have to come and pasara it. Pasara means she has to come and break it down to us again as she comes back. Your questions are answered. Head nurse and deputy are already going out to collect those questions and answers. So let's listen to Sweet Mother by our own Ebony Waves. Ask your questions. You can ask questions outside what we are taught today, but let's concentrate on asking Dr. Yemisi today. I don't know, I keep on calling her Dr. Limas. Thank you. Well done. Wow, wow. Let's put our hands together for these young men. They are all members of the DIFF Medical Center. They work in various departments, and you have seen them like this, but they have come to show their talents here. You have your wedding anniversary, you have your, oh, see one of their members going. Your wedding anniversary, your naming ceremony, your whatever event you want to, these people are available for you. For procession, you want to do some procession, they are here. Let's put our hands together for them once more. Well done, well done, well done. I saw that 4-year-old child. They'll be beating him. Some will say it is witch. Some will say no, it's spiritual attack. Some will say everything. It's ignorance. Ignorance and availability of knowledge. Thank God that the mother volunteered that you could show us that picture. It's very, very disheartening. I felt very bad in my spirit when you were talking about that boy. I'm sure you will start answering the questions. Head nurse is ready. Take your mic there. Ask her questions. Maybe she'll also talk about cost for us today and elaborate further on some of these tests and how easily it can be done. Thank you. Go ahead with the questions. We are all as here to also support you. Sit down. No, you can sit down.
Good morning, CMD sir, DCS, DDCS, Dr. Bendo, Dr. Barrow, ladies and gentlemen, good morning. Our amiable, beautiful speaker today. Thank you, ma.
Thank you.
I have some questions with me here. The first one says, what if you have your baby speaking like ta in 4 to 5 months? Does it mean he or she can have hearing problem? That's one. Then the second question says, what is the cost of the hearing aid screening? The cost. How much does it cost? Then another question says, what is the protocol for screening? And is DMC doing anything to sponsor a bill for the legislative to be passed? Then another question says, is it possible for the training materials to be sent to our emails? Then the last question I have here is, if the hearing loss is detected and treated early, can the child hearing still be like that of every other normal child? Thank you.
Okay, thank you very much for these very intelligent questions. Let me just stand here and address them one after each other. So now, if your baby blabs at 4 to 5 months, I don't really know what it was, maybe blabbing, it is not a way of saying that the child hears well or the child is going to talk. There are some sounds that even these deaf children make. Yes, they make some sounds. And at that age, it's very difficult to differentiate whether it's the child wants to talk or the child is just holding like the deaf children. So we don't use that actually to determine whether the child will talk, even though we know that there are some milestones that a child should achieve at particular age. For the person that asks for the material, when I'm sending it, I'm going to send these milestones step by step, things you can also watch out for. And that blabbing you're talking about must be what we call some form of meaningful blabbing, not just things like the child is just holding. It must be something like the child wants to talk. I really don't know if you can actually use that or you can be very sure with that. It's not a reliable test. If you have done a screening for that child, you don't need to bother whether this blabbing is normal or not. You don't need to bother. The standard is screen the child. Just screen the child. Don't start using crude methods. Okay, because a lot of parents will come. Parents that are, in fact, right from when I've been doing this test, I've never screened a child less than 2 years. They always come after 2 years. And they will tell you that when this child was 9 months, he was blabbing. He used to even say things like sounded like bye-bye. You know, the child was saying, almost say something like water, you know. And, you know, parents are very positive about their children. So they believe that the child was beginning to talk at that time, but now he's not talking again. And at that point, there's a confusion. Okay, was the child really beginning to talk at that time? Was it something that just developed now? Or was it that the child had always been deaf from birth? So to avoid all these doubts, all these stories are, okay, the child was beginning to talk, was blabbing, and then now the child is not hearing. What happened? It's always better to screen. I don't know if I answered the person's question. Then for the cost for the ABR, for the OAEs is 40,000 naira. You have to do an OAE is 40,000 naira. Then the ABR too, I think is the same thing. I actually need to be sure of what's on the EMR. But I think the last time I checked was 40,000. But if you are going to do a comprehensive auditory screening, hearing screening that covers from the tympanometry, OAEs, DPOAE, TOAE, ABR, and all acoustic reflexes, that is 130,000 naira, because that even involves sedation and monitoring of the child. And that test takes about an hour. So time that I will have done adenoton selectomy and finished. You will sit down there, you put up the AC, everywhere is hot, you are sweaty because you don't want any sound, you know, and the equipments are very, very expensive, and you can be sure about that if you are not buying a China equipment. So I don't think that is actually expensive. Then the protocol for screening. Well, the protocol for screening is what I highlighted. The child is born, we screen before you go home. The child is in NICU, the child does an OAE and an AABR, because the child is in NICU for at least up to 5 days. You know, or a child that has risk factors. Every child should be screened. That's number one protocol. Every newborn should be screened. And then there are some that will now require follow. By the time we do the initial screening, we'll let you know if your child requires follow-up visits or if your child requires, based on whether the child falls under the high risk register category, whether the child has had exposure to, has had jaundice, was in NICU and things like that. So that's basically the problem. Then as per whether Bill is doing anything to sponsor a bill, whether DIFF is doing anything to sponsor a bill, I can tell you not yet. We are just starting as well. And before you can sponsor a bill, you must at least have started something, and then you start pushing for it. We are starting, and then we believe that we'll get there by God's grace with the support of our MD, who I know always goes for the best and he wants to be the first in everything. So I believe that we can actually be like the trailblazer in this area. And then the materials, yes, you can drop your emails. I can send the materials to you. And then the last question was if the child's hearing. I didn't really finish writing that.
Says, if the hearing loss is detected and treated early, can the
Yes,
child...
if the hearing loss is detected, an intervention is given before the age of 6 months. I'm telling you, the child will hear like any normal child and talk like any normal child. What is important is that the child starts to get sensitized to sounds from birth. If a child does not hear, the child cannot talk. It's what they hear, they say. So what is important, the child starts to hear sounds from as low as when the child is still less than 6 months of age. Once the child is hearing the sounds, is hearing the speech, the child is forming his or her own speech as well. So any child that has intervention before 6 months or latest by 6 months will develop like any normal child, because the child is hearing and the child will form his or her own speech and talk normally. But it is when the child is now rehabilitated late, after 7 months, you know, that is when some of them will actually get to talk, but it will not be at par with their peers, their contemporaries. It will not be at par. And depending also on how late the rehabilitation is, like the one I was telling you, 4 years and above, you know, the child may just hear sounds, but You know, in fact, I still had a 30-something-year-old woman who came recently, was born deaf, but there was no information at that time, no awareness. So the siblings just knew that this our sister never talks, they grew up. So one of them now became a big man, he travels abroad. And I realized, this my sister, why is it that her own case is different? Why can't we do something about her hearing? She came, she's married now, married a deaf person, as you know this deaf culture, married a deaf person. Fortunately, they have a child that hears and can even talk, you know. But the woman is used to this deaf. So the man brought both the husband and the wife, his sister and her husband. I want to test them. I told him this is very late, 30-something years. There's really nothing. He said, I just want us to try. Just let us try. Even that she's a woman, she goes to the market. Sometimes car is passing, let the car not hit her and things like that. Let her be able to hear horns. Let her just speak. Anything we can do. So he was willing. We did ABR. The husband's own there was no wave at all. But the woman had some waves as 80 decibel. 80 decibel. That's very loud sound, like the sound of aeroplane. She could pick, but she could not hear. For of course, at that time, you don't expect her to start understanding speech or to start talking. So I told him, this is the best that your sister has. He said, can you get very high-powered hearing aids? I just want to amplify the little, because she has some little residual. I want to amplify this little. Let her just be aware of warning. In the house, they are sleeping in the night, someone is banging at the door. They just warning for, safety. Even hearing is important for safety, security. You need to hear things. We got the hearing aids for her, and the man is so happy. He has been referring people to me because he said the sister has really improved. Sister hears, she can now turn to sounds and things like that. Even though I don't expect her to talk or to probably understand speech, but that they are very happy with the improvement they have seen since she started wearing the hearing aids. That's at 30-something years. So I think it's actually very good to have everybody, evaluated. Any other question?
Thank you.
Okay.
Thank you once more, Dr.
Okay, thank you
MC.
very much.
To pass a bill in National Assembly, the CMD will be coming to round up now, and I'm sure he still has some questions for you, and then to give his usual roundup. To pass a bill, private bills are difficult to pass. Even government bills are difficult to pass. Our National Assembly, I don't know whether that will generate money for them and all that. It needs professional body. Our professional body, NMA, SOGON, ENT Association of Nigeria. SOGON is Obstetrics and Society of Obstetrics and Gynecology in Nigeria. We need such powerful bodies to go through the Medical and Dental Council to the Federal Minister of Health to be able to get to where we can even get this bill. Health bill has been there lying down for donkey years in the National Assembly. Maybe because they are not generating money for it. I know. That's why we're doing this advocacy. I'm sure some of you are here that have influence over these people. Maybe you help us to talk to them. But I don't know whether our people are ready. They like good things. They go outside to acquire, like the man that you just gave example that is trying to help his sister. People go outside and do things, but they don't want it done in our country. It's very sad. I would like to appreciate each and every one of you. Once you guys, let's put our hands together for Dr. Lima. I mean, hey, Dr. Emisi, please forgive me. I know you before I know Dr. Lima. I don't know what's... Maybe because Dr. Emisi, Dr. Alima was the last person that examined me. You examined me about 3-4 years ago. That's why. Bear with me, don't worry. We'd like to invite Dr. Dausa, our Chief Medical Director, to make some input into your lecture and possibly ask some questions and guide us again on what to expect. Let's put our hands together for him.
Thank you, Dr. Yemisi. I won't make the mistake. Because you examined me, Dr. Halim also examined me last month as part of my annual medical check. And thank you for the great job she did. Thank you for helping me to be healthy so that I can continue to deliver. Thank you for the lecture. And it's always nice seeing young people deliver things the way you do. Thank you. Everyone seated here needs medical checkup. She is saying that is the newborn. We all did. And so what if I must promote a bill? It will be to introduce preventive medicine to the National Health Insurance Authority. They should incorporate it into our lifestyles. The misconception is that something must kill a man, something must harm a man. The misconception is that what's going to be is going to be. What goes up must come down. It's not true. Now we know that if we can detect these things early enough and start treatment before 6 months, that these children can live their healthy life. And it's just for 40,000 to 130. Honestly, medicine is cheap here. Dr. Yemi said, I think I was in the US 2 years, and we're just passing through a geometry center, and my wife just took an interest. We're talking about thousands of dollars, you know. So I actually thought you were going to say 1.something million, but since it's 130, I think every child should be subjected to it. If you doubt it, see, curative medicine is more expensive than preventive medicine. Why should we have waited for a woman to be 30 years old when it could have been avoided? People say that ignorance is a bliss. And so we are using this forum as a means of empowering people. I may not be able to influence the National Assembly because sometimes it appears what the National Assembly is interested in now concerning the health sector is how to prevent doctors from leaving the country, either by seizing your certificates, seize your visa, seize your passport. But that should not be it. We should make it very interesting for people to want to access medical services compared to what is obtainable in the Western world. Thank you, Dr. Yemisi, for bringing those gadgets and facilities that we can do them now. Very proud of you, and we hope every mother here will try to screen your kids. Now let me tell the Department of Pediatrics, please, babies that spend 48 hours in NICU, in the neonatal intensive care unit, please don't allow them to go home again without processing them through the ENT. We'll put it this way, distinguished consultants, gynecologists, that if our patients want to go home and they don't want their babies to be screened for financial reasons, let's give them paper to sign. So let it be that we did our best, but that they have refused. You are talking about screening. There are still women who don't screen for simple things like cancer of the cervix. Why should, in 2023, a disease that has been eliminated in the Western world, why is this still a prayer point? It has to do with the trappings of our background, the culture, our custom. The concepts of popular opinion that just makes us believe that, well, the man of color, something must just harm him. It's just the way we're born. And thank these people coming here and send you out now as our advocates, as our beacons of hope. We're sending you as our torch bearers, as our light bearers to go and tell other mothers in other places that your babies must be screened. For those of you who are going to deliver abroad, from my experience, When you are coming back, they will give you a family planning device. They'll give you Mirena. Bring it if you want to live. I have seen that form on ear screening on women that come from abroad. There's so many things, so many papers you have to sign. And that's what we're now trying to do. A time may come, we might not be able to travel outside the country. After all, it happened during the COVID. Governors, ministers were forced to take their deliveries here. And so we needed to do what is obtainable also in the Western world at maybe very minimal cost. Thank you for making it that cheap. Dr. Yemisi, I want to ask a question. You said that we should do this test before 6 months. In fact, we should start it within 48 hours of birth. You think it is really possible to put something in a child's ear within 48 hours and the child will allow you? Secondly, I said I went to an audiometry center. We were just passing by and we just saw it. I noticed the cubicle was soundproof. So, but the place was still cool enough to prevent heat. How do you intend to design a soundproof environment devoid of heat so that our children can cooperate? Now, for a 2-day-old child, the mother must hold, which means the mother must not make noise. Is this scientifically possible? And I would have loved you to demonstrate. If it is possible, a doctor is coming to talk to us on preventive medicine. We can beam you straight from your clinic while you are doing it, and we are watching you here, and then we'll be asking you questions so that we can put practicality to this scientific enigma. But just give us an answer and say, let's see what is possible.
Thank you, sir. I had actually been having palpitations while expecting your question. But at least it's what I can have, because his questions can be very, very, very toxic. Actually, sir, it is possible to do this screening on babies that's young. For the OAEs, it can be the ones the child has been fed. You know, they sleep deeply, especially in the morning. It's not a test that takes time. And then the equipment comes with probes of different sizes.
Okay.
For the ones for babies, very tiny probes. And once these babies are deeply asleep, you put it there like silicone. Put it in the air. The machine measures it very fast. And then they won't even move. Yes, and then for the OAE, you don't really need a soundproof booth. You just need a very quiet environment. Put off everything, AC, fridge, and all of that. You can just, and then the machine is such that it tells you when the noise level is acceptable or not. It measures it. So once I'm doing it, I'm seeing on the machine, it's telling me, sometimes if the noise is too much, it will just tell you noise too much. You will stop running the test. So whatever test you do with that machine, that's why I say don't buy China. Whatever test, you are sure it's reliable, because it will tell you the noise level as you are doing it. It will tell you the stimulus level and all of that. So once you are doing it in the right environment, the machine approves, the result is out, and it's reliable. So you can actually do it, whether the mother is holding the child or not, doesn't matter. Once the child is asleep and quiet, it's not making sounds or sucking or anything, you can quickly run your test and come out of it. It's actually done on the ward or in the clinic. The soundproof booth, that one comes in when you are doing what we call a pure tone audiometry. That's a hearing test, and usually it's done for children 7 years and above. Okay. Now, this is the one that you stimulate them. We give them instructions. It must be children that are intelligent, and then for adults. You tell, when you hear, I'm going to give you sounds in your ear from these headphones. When you hear, you press this button, so it shows, and then we measure a graph from that. Now, that requires a soundproof booth where, well, noise cannot enter from outside. But nowadays, because soundproof booths are now getting obsolete, they occupy space, they are to even buy them and ship them and all of that. Now they are audiometers that comes with inbuilt soundproof booths.
Okay.
So you are putting the headphone on the patient. That headphone gives you the soundproof booth you need. You don't need to get a physical soundproof booth. But for now, I don't have that, but that is the next gadget I want to buy. That's the last audiometric gadget I want to buy. The one soundproof booth, the audiometer that comes with its own soundproof. So that I don't have to build a soundproof, which is usually like a small cubicle. So that's audiometer, you know, just it's inbuilt in the machine. You don't need the soundproof booth. But for now, what we do is, I'm sure people who are on Block B already know me. I know some of them make fun of me. Because when I'm doing my tests, everybody has to be still. They have to put up the music on the corridor. All the staff passing must not talk. Everybody knows that it is be still. Dr. MC is doing tests. Once you have a very quiet environment, it actually subserves for now. Then the headphones too are very airtight. It blocks out any sound coming from outside. And even the patient can tell you that, no, I didn't hear any interfering sound. And at worst, even if you envisage that there was some level of noise, we can measure with our noise meter what level of noise there is. You subtract that decibel from the results of the test so you can get an accurate result. So there are still ways around it. But what I do for now, we switch everything off, AC, everywhere is quiet, phones are off, and we actually get very reliable results. Thank you, sir.
Okay, thank you. Please, just before you say that,
Okay.
Pregnancy, does it make women deaf? Or does it reduce their hearing?
Well, sir, pregnancy is a physiological thing. It's not supposed to be a sickness.
Okay.
It shouldn't make women deaf. But indirectly, it can reduce their hearing in the sense that there's so much fluid accumulation everywhere.
Correct.
And then some of them, when they get pregnant, they start having runny nose, blocked ears, the station tube is congested, they have fluid in the middle ear. It can actually cause hearing loss for them. And once the baby is out, the symptoms should resolve. But on its own,
Okay.
ordinarily, if they don't have all those other issues, it's not supposed to cause hearing loss.
Okay. I just want to recommend that our pregnant women here, once in a year, should
You
please
should come
visit your department, visit your hospital.
At
visit
least they
your
can have a
unit
tympanometry.
for the kind of thing you did for me.
Yes, sir.
And you gave me a clean bill of health. Has
Yes,
Dr.
sir.
Osman come?
Yes, sir. Sir?
Dr. Osman, has he come? Dr.
He has not come this
Please, you people go and meet her. You will find her very useful, and then we extend it to our clients. Please go to her to test you whether you are okay. From there, go and meet Dr. Halima it's called preventive medicine. I think we'll stop here because the day they are going to talk about preventive medicine, a lot of people are going to talk and tell you why you must do some things so as to make sure you are healthy. Finally, let me thank you, distinguished students. Thank you, doctor, for giving us opportunity into your lives, into your spare, into your family. We don't take it for granted. Thank you for giving us these 2 weekly opportunities to share thoughts with you, trying to bring our 37, or bring my own 37 years of experience. Dr. Osman's maybe 35, Dr. Okonkwo's 34, and so on. All of us here bring our clinical experience. Today, I may be the one that is passing a critical mass of information that may change your narrative. Tomorrow, you may have the information that will change my own life, and you become my destiny helper. The bottom line is that neither he who gives this information or he who receives the information should take any glory for the goodness. So we know where to lay the trophy. We give it back to God who gave this knowledge for us to share. Have a very great weekend and enjoy your Easter. Thank you.
Thank you, sir. We'll see you again in 2 weeks' time. By the grace of God, on 22nd, we shall have another loaded session by the grace of God. Some of you may be delivering within the next 2 weeks. Maybe I'm trying to see if I can identify. And in the next 2 weeks, if you are going to be delivering, please come forward at the end of the lecture, meet the head nurse and a deputy for the last extramural class. And if you have not packed your package, your boxes and everything, she will teach you what to do. For those of you that will be delivering, maybe you want to go and see the labor room also, talk to your consultant so that, or head nurse. Head nurse can even arrange for you to go and see the delivery room. We don't call it labor. Our women don't labor. Why should they come and labor? Labor is a thing that you should be this thing with your husband and watching films and all that thing and baby come. It's for those of you who don't want to use epidural. That's why you'll be shouting and tearing our dresses. We'll say your husband must come and stay there with you so that we deliver a baby earlier hours of this morning. I'll talk about something to do with that maybe in 4 weeks' time later when I'll be teaching something else. We'll be on our feet as we take the DIFF anthem and then the second stanza of our national anthem. I want to appreciate each and every one of you for coming. Let's be on our feet. DIFF anthem and the second stanza of national anthem.
Together bringing hope for the joy of mankind, committed to excellence, home and abroad, motivated we are, together we stand. God bless this legacy. God bless this legacy. Decentralized sectors yet integrated, effective and harmonious workforce we are. Erase mortality, encourage research. God's grace is what we enjoy. More grace to this legacy. O God,